Good day, everyone. I'll say good day because I know we're in multiple time zones. I'm Theresa McLoud. I'm a thoracic radiologist and a member of ICIS and a fellow in ICIS. And I specialize, as I said, in thoracic radiology at the Massachusetts General Hospital and Harvard Medical School. And I'd like to introduce Dr. Brent Little, who is also a thoracic radiologist in our department at Mass General Hospital. And he's going to start off the presentation entitled Manifestations of COVID-19 in Cancer Patients. I want to welcome all of you to the webinar.
Thank you so much. And I am going to start by discussing the manifestations of COVID-19 for all patients. And just wanted to start by talking about the general appearances of COVID-19 for just patients in general, because it's relevant for cancer patients. So we'll discuss what's the typical appearance of COVID-19, and then we'll talk about the sensitivity and specificity of the imaging findings, because that really puts things into context. And then we'll talk about some of the implications, and Dr. McLoud will go on to specifically talk about the implications for cancer patients. So there are multiple international and national guidelines for the use of imaging in COVID-19 and suspected COVID-19. I'd like to remind you of that. When you're looking at this afterwards, you can point your camera to these QR codes and then it'll bring up these guidelines. But they all focus on a few simple tenets. And one of them is that imaging should not be used for the method of primary diagnosis. That is actually reserved for testing, laboratory testing, PCR testing, nasal swabs, and so forth. It can be used, imaging can be used for problem solving and to help pick up unsuspected cases. And I think that's a lot of what we're going to focus on today, how to suspect the typical appearance of COVID-19 so that in cancer patients or any patients, you can suggest that diagnosis when relevant. Also to make triage decisions about who might be admitted to or need admission to the ICU or to the hospital. And then to talk about complications, to assess for complications like pulmonary emboli and other infections and barotrauma, things like that. And also to guide therapy. Are patients getting better or worse via imaging? It's important to know the common appearances of COVID-19 pneumonia at CT and radiography. And here's a CT showing the typical peripheral and bilateral ground glass opacities. Sometimes you can have a little bit of consolidation, and the consolidation becomes more common later on. And it can, importantly, sometimes be somewhat band-like or round, and it can look somewhat like organizing pneumonia, perhaps because many times it does represent an organizing lung injury. And here's another patient with a typical appearance of COVID-19 at CT. You can see the multiple, somewhat round, peripheral, bilateral ground glass opacities here. And we'll talk about how this appearance is not, certainly nowhere near 100% specific. But here's a radiograph showing the typical appearance of COVID-19, especially in the intermediate to sort of later phase, where you have bilateral opacities. These are hazy opacities with some areas of more confluent round opacity bilaterally. And here's another case that shows you can have a variety of appearances of COVID-19 at both radiography and CT. This one is a little more asymmetric. You can see this peripheral, somewhat band-like opacity along the left lung, and not much on the radiograph in the right lung, maybe a little bit down here. But the CT, coronal CT image corresponding to the same patient on the same day, shows how CT can be more sensitive for detection of some of the opacities. And you can see that this truly is bilateral and patchy and peripheral. And this slide highlights some of the other findings you might see in COVID-19 in a minority of cases. You can see what can be seen in other infections. This is known as the halo sign. It is a nodule that's solid with surrounding ground glass hazy opacity. So this is the so-called halo sign. Remember, it's not specific for COVID-19. It can be seen in fungal infections and can be seen in other viral infections, but it can also be seen in COVID-19, and that was a case of COVID-19 pneumonia. And something that can be seen frequently is the reverse halo sign. Now, the reverse halo sign was described first in organizing pneumonia, but now we know it can occur in a lot of different processes, including other infections and of course, COVID-19. You can see that the reverse halo is actually a rim of consolidation with internal ground glass opacity. You can also see what is called a target sign. Now, the target sign is a reverse halo like this, within another reverse halo. So multiple concentric reverse halos, that is the so-called target sign that has been described in COVID-19 in some cases. And it's important to know that just because your CT or radiographs don't meet the typical appearance for COVID-19, it can still represent COVID-19. You can see in this case of what looks like just any other viral pneumonia, or perhaps other processes like pulmonary hemorrhage could have this appearance. It's just bilateral, fairly diffuse ground glass opacity. And you could, of course, see this in a lot of different things. And this turned out to be a patient with COVID-19 pneumonia. I would have given in my differential any other viral pneumonia as well as other processes. Now, what's the sensitivity of imaging? It's important to know that these two CTs that are actually negative CTs actually belong to patients who had COVID-19 and had respiratory symptoms. So chest CT can be normal. So what's the sensitivity? Well, if you take patients in the early period, that is the first couple of days after symptom development or an exposure, 44% is the sensitivity. So that means that 56% of the CTs can be negative in that early period. That's why PCR is really the gold standard, and nasal swab testing, nasopharyngeal swab testing has been the gold standard for detection of COVID-19. But it's important also to realize as imagers that nasopharyngeal swabs and PCR has had as low of a sensitivity as 70%. And now most of the studies are showing it's about 80 to 90% sensitive, but still not 100% sensitive. Now, in the later period, imaging actually develops into a more sensitive modality. So compared to PCR, CT in the late period has about a 96% sensitivity. So something is abnormal in 96% of patients in the late period, and that is 7 to 10 days after onset. So you can think about, why do we get some false negatives on PCR swab testing, and how does imaging play a role here? Well, you can think of a typical patient as having a pre-symptomatic period of after exposure here, having pre-symptomatic period, and then they can have symptoms or they can remain, as we know, many patients do remain asymptomatic, and then they can start to become convalescent and, and get out of the symptomatic period. Now, PCR can actually be positive. It's not common, but it can be positive in really the pre-symptomatic period. And then sometimes you can have false negatives in the symptomatic period, even in the first couple of days. And then even when PCR turns positive, sometimes it can then give you a false negative. And then in the convalescent period, it can stay negative for a bit. And then we know from some other studies that even weeks after exposure, sometimes the PCR can be positive. It doesn't mean the patients are symptomatic, but it can turn positive again. And this has to do, these false negatives have to do with host factors like viral shedding on some days or some times of days and not other times of the day. And then testing techniques. So testing can be adequate, or testing can be shallow swabbing and inadequate swabbing, and that can lead to some false negatives. Meanwhile, what role does imaging play? Well, the interesting about imaging is that for chest CTs and radiographs, if a patient has a positive study, it takes some time for it to return to normal, for it to return to negative. So that means that if the CT or radiograph turned positive at this point, you might pick it up anytime that you scanned for all of this period until it became negative. So meanwhile, PCR could be intermittently negative. So you could presumably have, and I've seen this happen multiple times, you could have a negative PCR, findings that look like this, and then suggest that the patient be tested again and prompt additional testing, whether that's a nasal pharyngeal swab or a sputum sample, and then the next PCR can come back positive. So you can really play a major role as an imager if you suspect COVID-19. Now remember that in the early course, it can have some atypical appearances. This is more unilateral and unifocal on this radiograph. And this is very unilateral in the right lung on this particular radiograph in the early period. Now here's a study that shows these CT appearances and how they vary based on the time course. You can see that on day 3, very early in the course, you can have just a single opacity. And so this would be hard to diagnose as really anything. This could be many, many different conditions and infections. And then later in the time course, it tends to be more bilateral and multifocal. So here you can see the so-called typical appearance of some ground glass opacities, a little bit of consolidation. Here is mainly consolidation and bilateral and peripheral. Of course, these are not 100% specific appearances, and we'll talk about that in a second, but remember the time course. Here is another thing to remember, that radiographs are actually not very sensitive in the very early setting of after exposure. This is a patient who is symptomatic, had multiple negative radiographs. And so this patient was positive for the virus, however. And what is the sensitivity of radiography? It's pretty bad. We can look at symptomatic patients who were hospitalized, and you'd expect most of these radiographs to be positive on admission. And you can see in this particular study, PCR had a very good sensitivity of 91%. But how did radiographs do? Well, 31% were actually normal, and an additional 41% had only mild opacities. And so that means at best, only 69% sensitivity for radiographs. And remember, this is in admitted patients and most of whom were symptomatic enough to require admission. And it gets even worse because if you look at the urgent care setting, the ambulatory setting, patients are presenting even earlier. And so if you look at this study, the largest study to look at over 600 patients in urgent care clinics, how many radiographs were actually, were actually positive? Well, 58% were normal radiographs. And it gets a little bit worse because that was actually in the study when the readers knew that the patients had COVID-19. And so how did they do in the original setting when they didn't know? For the clinical reads, 74% were actually read as normal. And so all of these patients had COVID-19. And there was a reason they presented to urgent care. They were symptomatic, but these were read as normal. So interpretation of imaging does require context, and it's important to know the so-called typical bilateral and peripheral appearance for COVID-19. That would suggest that you could make that as a suggestion for a diagnosis if you see that. However, in the early setting, you may have radiographs that are atypical, that have only a unifocal disease or have unilateral disease, or as we saw, it can look like any other viral pneumonia in some cases, or you can have this, you can have a negative radiograph or CT. So time is really, since exposure and onset of symptoms, if you have symptoms, is really one of the factors you need to think about. The other factor that we're going to talk about right now is other causes of the findings that you think might be COVID-19. So we'll talk about that. So this is one of the key roles of imaging and appreciating the so-called typical appearance of COVID-19. All of these cases were actually unsuspected cases of COVID-19. And all these patients were symptomatic, but you can see they range from sort of this non-specific appearance of just a little bit of ground glass opacity to this was a patient who had some aspiration-related pneumonia and also had COVID-19. But then these 4 patients are ones that we suggested could be COVID-19 just from the imaging alone. And you can see the typical bilateral ground glass opacities, and this is a peripheral distribution. And some of these patients, actually, this patient was a cancer patient that we detected this in. So what is the specificity of imaging? It's certainly not as good even as the sensitivity of imaging. You can see here a couple of radiographs from patients who have hazy, bilateral, somewhat peripheral opacities, and neither one of these was actually due to COVID-19. They were both before the pandemic started. And you can see the CT corresponding here. And this was actually H1N1 pneumonia. So remember that influenza pneumonias, including H1N1, can have that same appearance because it's a sort of an organizing lung injury. And also, this is a case of cryptogenic organizing pneumonia, and it really highlights how many similarities you see between organizing pneumonia due to other causes and COVID-19 infection. And here's a case of influenza pneumonia. You can see as I scroll through this that you have bilateral peripheral, somewhat nodular ground glass opacities. We scroll down, there are multiple of them. And in the setting of a pandemic of COVID-19, you would want to suggest that this appearance could be seen in COVID-19, but of course this was not. This is influenza pneumonia. So other infections can have this appearance as well. And what about these? Which one of these CT slices that would be typical for COVID-19 actually turned out to be COVID-19? Well, not a single one. This was influenza pneumonia. This was H1N1 pneumonia. This was respiratory syncytial virus. And finally, this was not a pneumonia at all, not an infectious pneumonia at all. This was organizing pneumonia due to a drug reaction. And Dr. McLoud will be talking more about that. Here is a patient who had similar findings, peripheral opacities, and a little bit of the so-called perilobular pattern where you have these band-like opacities at the lung periphery. But this was not due to COVID-19. This is a drug pneumonitis in a cancer patient. So it's very often a similar pattern, unfortunately. And so this pattern is common in both COVID-19 and in patients on drug therapies. And it's important to note that if you have a patient on drug therapy, and Dr. McLeod will talk more about this, COVID-19 infection could potentially potentiate or synergize with those effects and make it worse. Now here is a patient, I'll show you this. I want to ask you a question about this case as I scroll through. I'll go down to the lung bases. You can see that there are bilateral ground glass opacities. And this pattern I've just told you is typical for COVID-19. If you see this in the setting of having cases in your community, you should suggest that COVID-19 could be a possibility, but do you think it's COVID-19? Actually, this case is not. It's another case of drug-related pneumonitis in a patient being treated for breast cancer. So appearances are very similar. All right, so just in my last couple of seconds, and it's important to know the time course and whether the patient is on drug therapy, of course, when you're considering drug-related pneumonitis. Now, just lastly, I want to remind you, I've talked mainly about the thoracic manifestations of COVID-19, but it's a multi-system disease. Not only can it cause pneumonia and complications within the lungs, can also affect the GI tract. It can cause bowel wall thickening, it can cause bowel ischemia and nausea, vomiting. It can cause cardiac complications like myocarditis and pericarditis. Can also cause renal damage, can cause renal infarcts and renal failure. Can cause, of course, strokes and other dizziness and confusion as well from brain effects. And as we know, it can cause loss of smell and also conjunctivitis, as we're coming to appreciate more and more in a small set of patients. Now, here's an example of this bowel wall thickening and enteritis that you see. This is from an MGH study that was published. This is actually a patient who had bowel infarction, and you can see the bowel wall thickening of primarily the small bowel here. You can see a little bit of early pneumatosis. You can see some fluid around the bowel loops. And this patient actually had to go to surgery to get this bowel resected. And the surgeons have commented that this is the typical kind of dusky appearance of infarcted bowel, but in COVID-19 patients who have this, they've seen this strange yellow appearance of the bowel, and which you can see here. So it can affect the bowel, can cause conjunctivitis, and also in keeping with some of the vascular effects of COVID-19 due to clotting problems, it can cause the so-called COVID toe phenomenon that can be due to in situ thrombosis and also due to thromboembolic effects on the extremities that you can see here. And of course, we don't see this a lot in adults, but in children, in adolescents, the multi-system inflammatory syndrome that looks a bit like Kawasaki disease and affects all the vessels and including the cardiac vessels can occur. And there's a high incidence, just to remind you, in both cancer patients and COVID-19 patients of pulmonary emboli. And the figures are that up to about 30% of patients in the ICU who have COVID-19 infection can have pulmonary emboli. And Dr. McLeod has done some nice publications on this very phenomenon. And it's important to remember also brain effects. And you can see here, this is a negative chest CT, and yet the patient had these diffusion-weighted images that show multiple areas of infarction within various parts of the brain. So the brain can certainly be affected, and brain imaging plays a big role in management of these patients. All right, so I'm going to turn it over to Dr. McLeod, and she's going to talk more specifically about cancer and COVID-19.
Thanks, Dr. Little, very much for coaching me here on high technology, but greetings to everybody. I'm going to talk a little bit more specifically about COVID-19 in cancer patients. I thank Brent for all the wonderful radiographs and CT scans he's shown of the different patterns and instances in which you can see COVID-19. I'm going to talk a little bit more about the broader perspective and some of the statistics that we have in relationship to COVID-19 and its effect in cancer patients. This is not advancing. Let's see. Okay, all right, okay, thanks. Let's see, okay, we skipped one slide there. There we go, all right. So the effects of COVID in cancer patients, obviously there can be adverse patient outcomes due to a combination of the COVID infection and the effects of cancer. The other important issue is the impact on delivery of patient care. I think probably all of you in this audience have experienced this in our own hospital when it became flooded with COVID patients at the heat of our pandemic, which in the New England area and the northeastern part of the United States was mostly in late March and April. The hospital really closed down for all elective procedures. The governor demanded that from all the hospitals so there'd be enough facilities to take care of COVID patients. And the usual patient care, the follow-up for cancer patients and all was pretty much halted. Now that was replaced a great deal in the United States and I'm sure worldwide by telemedicine, which was effective, but it isn't quite the same as being able to see the patient and directly talk to them and determine whether there are any complications or difficulties with the cancer, ongoing cancer treatment. And then the one thing as radiologists we may not consider, but there's been a very severe disruption in cancer research. At our hospital, MGH, we're the largest research hospital in the United States, and we closed down every laboratory. That was a state decision, I think was reasonable. And but you can imagine you spend about 6 months with no research, getting your lab closed down and then trying to reopen it again and take on where you left off in your research has been very disruptive. Now we talked about incidental findings. This, for example, is a patient came to the hospital early in the pandemic for lung cancer restaging, and astute radiologists here did notice the typical ground glass opacities that Brent was so nicely demonstrated. The peripheral allowed them a basilar, and even though the patient was not symptomatic with typical COVID symptoms, we alerted the team and the patient received appropriate treatment. And many of the patients with cancer, if the cancer is very active, will just have to be hospitalized, at least as a precaution if they're shown to have COVID disease. And here is a very advanced case of a patient with adrenal cortical carcinoma with typical ground glass opacities, but also had a very large right pleural effusion, all related to COVID infection. Now, I think Brent has already mentioned this, but the findings of COVID-19 can sometimes be mistaken for cancer. This was a young guy in his 40s. He was a heavy smoker, but he came in with fatigue. And of course, we read this chest radiograph and thought he had a mass there, and it certainly looked like a mass on the standard radiograph, and thought he might have lung cancer. And as you can see from the typical findings on the CT, that it's almost like a reversed halo here of this very localized lesion in the right lower lobe, and this was COVID pneumonia. Now, there is a lot of documentation in the literature, not surprisingly, of the high mortality of cancer patients with COVID-19. This was a thoracic cancer study, and that comes from the TerraVault registry. And 76% of the thoracic cancer, not surprisingly, were non-small cell lung cancer. I'll just move this over a little bit so we can see everything. 74% were on therapy at the time. 76% of patients with COVID pneumonia were hospitalized, and 33% died. So these are all patients with COVID pneumonia. You can see the very high death rate. You know, in the general population of those who become hospitalized, it probably is no more than 5 to 10%. And those that aren't hospitalized, you know, the mortality rate is well below 5%. Their risk factors have been definitely identified for increased mortality, and they include the usual risk factors in the general population with COVID, age greater than 65, smoking history, and other comorbidities such as hypertension, for example, or diabetes. Now, this is an interesting study, which was showing the high mortality of cancer patients with COVID-19. It was a meta-analysis of over 46,000 COVID patients, general COVID patients, and you can see about 1,700 actually had cancer. And the mortality rate in the cancer patients was high, and not unexpectedly, the risk ratio there being 1.7, and then for ICU admission as well, a higher risk ratio of 1.6 compared with those in the general population. And again, among patients that are hospitalized, you know, it's usually the patients that are obviously older and maybe more susceptible to, you know, other comorbidities. But this study just showed the cancer itself was obviously a very complicating factor that led to a higher death rate. Now, there's some studies addressing the incidence and others the prevalence of COVID-19 in cancer patients. And here are a number of studies, several that came from Italy and also from China and Europe during the height of the pandemic, so in the early to mid-spring. And the incident rates of COVID-19 in patients receiving active treatment for cancer, and these were asymptomatic patients, were between 0.79 and 4.2%. So fairly low, but again, asymptomatic patients. Now, the prevalence is a little bit different. If you look at the prevalence of cancer in patients with COVID-19, this is a large study that was based on data from 68 hospitals in Italy during their flare of the pandemic, 9,280 patients. And among those, the prevalence of cancer in those patients that wound up being hospitalized with severe disease was 8.5% had the diagnosis of cancer. Now, which cancer patients are most at risk? The prevailing evidence so far, there are two groups, those with hematologic malignancies and lung cancer. And obviously, patients who are very advanced stage of cancer are under active treatment. There are a couple of good studies dealing with hematologic malignancy and COVID-19. There's a strong association with hospitalization. Once these patients get COVID, they need to be hospitalized. They become very symptomatic. This was a cohort study from New York City at the height of the pandemic of 128 patients with hematologic cancers and COVID-19 infection, compared with 226 healthcare providers that had COVID-19 infection. Now, it wasn't clear from the information how symptomatic these were. I'm sure the healthcare workers were tested repeatedly and often, but when you compare them, it's still a striking difference. Case fatality rates for the leukemia patients was 62% versus 0% from those that were detected in the healthcare workers. Now, what about lung cancer? And this is another study from a New York City hospital, 102 cancer patients with COVID infection, and the death rate is around 25%, and 62% required hospitalization. And when you look particularly at cancer patients across the board, with the exception of the hematologic malignancies, the death rate once they have COVID tends to be around 25%, so much greater than the general population, obviously. Now, we talk about anti-cancer treatment and chemotherapy, and Brent has already alluded to this, but the prospective cohort study looking at the clinical and demographic characteristics in COVID-19 outcomes in cancer patients. This came from the UK, from the Coronavirus Cancer Monitoring Project. And they looked at cancer patients, all of whom had positive PCR testing, and all were symptomatic with COVID. Study of 800 patients, about half had mild disease, but 28% of the cancer patients died, again in that range of about 25 to 30% when they develop. Now, the risks of death also associated with several other factors, not just having cancer, but advancing age, which is true in the general population, being male, sorry guys, but that's true in the general population as well. And then the obvious comorbidities that we know about, hypertension, diabetes, cardiovascular disease. Now, this I found very interesting. This is a study, it was published in Lancet, and I'm sure we need more data, but this was a little surprising to me. Cancer treatment within the previous 4 weeks, and it was any type of cancer treatment, radiotherapy, immunotherapy, cytotoxic chemotherapy, hormonal therapy, had no effect on mortality in those patients with COVID when compared with those cancer patients with COVID who did not have active cancer treatment in the previous 4 weeks. So the ones that were being actively treated and versus those that in the 4 weeks previous to their acquiring COVID did not have any active treatment. They were just being, either restaged or monitored or whatever. No difference in the rate, which I thought was interesting. Now, maybe the sample is not large enough and we'll see variance as studies go forward. But now we talked about this. Immunotherapy is a blessing and a curse in the COVID age. We know that many patients now are on immunotherapy, and it produces an immune response, obviously, but it can also stimulate a general immune response leading to severe pneumonitis. And we talked about that, and Brent has referred to the fact that organizing pneumonia, which can sometimes look like pseudoprogression of the tumor, can occur quite frequently. When you combine that with COVID-19 pneumonia and the ICI pneumonitis, you can imagine that the degree of lung damage is going to be more severe. And in fact, there is association with ICI therapy and a cytokine storm, which is usually the last, when the COVID pneumonia is less active, but there's a tremendous immune response resulting often in death to patients with advanced disease, and now, of course, treated with methylprednisolone to prevent that last stage of the tremendous inflammatory response. So patients who are on anticancer immunotherapy are particularly susceptible to this complication. Now, I thought I'd wind up by talking about effects on cancer screening. There's no question from all the literature there's been global interruption of cancer screening of different types of cancer. Decrease is estimated around 80 to 90%, and mainly involves, of course, the screening that's done routinely for lung, breast, and colorectal. And when the questions come up from the audience, I'll ask you, because you're representatives from all over the world, how well established lung cancer screening is in your country or your community. This was a UK modeling study, and that it is a modeling study. It's just a prediction. And we've seen so much modeling about COVID in so many aspects, I'm not sure what I want to believe. But anyway, what is the impact on survival because of the interruption of the cancer screening? And this group suggested that based on this study, there could be an increase in deaths after initial diagnosis of 4 to 17% because of the lack of the interruption of screening. So the mortality rate would be higher once the cancer came to clinical observation. Now, this is some data. You may wonder if this is a respectable journal or not, the Wall Street Journal, but anyway, it's Republican, but I won't say any more about politics here, but I think this is valid data from United Health, was a large health medical insurance system within the United States. And they've looked at the effects of the COVID epidemic on screening. And on your left is a graph dealing with colorectal cancer. And again, the pandemic was at its height starting on the East Coast of the United States in mid to late March, and then spread through the rest of the country, and then dropped in the summer. And as you can see, the screenings hit quite a low and then began to recover sort of in the July and August, and almost back to normal levels. And the same with mammograms, perhaps hit even the hardest. People women just didn't come for their mammograms. And here on your right is from diagnostics lab test orders, and you can see the fall that occurred in orders for breast cancer screening. What we did in our hospital, screening can be available. I'll just interrupt a little bit and say, at least in the United States, screening can be available at multiple centers. There are imaging centers that are not in the hospital where many people get their testing and their screening done on a regular basis. But at the hospital at the height of the pandemic was not encouraging outpatients to come in unless it was really an emergency. And people were afraid even to go to these imaging centers where there were no COVID patients and where there were these imaging centers managed by healthcare workers. There was wonderful sanitation, all the rules of masking and social distancing, everything were observed, but people were afraid, and just because it was a pandemic, of getting routine screening. And you can see that in all the different types of lung cancer. This is our own experience at Mass General Hospital, and I thank Brent for putting this together. We had a hospital-wide policy of postponing elective imaging and visits during the surge, at least in the hospital setting. We have pretty large lung cancer screening programs, so our volume dropped tremendously. And now it's beginning to come back, as you can see from both of these graphs. Now, patients who had a positive finding, say a small nodule that we wanted to follow, and it was kind of borderline, so we wanted to follow up in 6 months instead of them coming back for their annual screen, that returned from baseline to pretty normal because patients knew they had an abnormality and they wanted to be followed up. But for the baseline and the annual routine exams and those who have negative studies, we haven't really recovered to full level at the present time. And I thought that, we ought to address the issue of people's attitudes. And sometimes I think well, in the United States, as you can imagine, the conversation about healthcare policy is very muddled. And I think you know who's doing the muddling, but that's okay. But I think patients sometimes just don't understand the risks and benefits of screening, even in a pandemic. And this was a study of 535 women in the US. Nearly 1 in 3 delayed their mammograms due to COVID-19. 29% that said that breast health had become a lower priority due to COVID-19. Now that may be due to their domestic situation. The kids weren't in school, they were trying to take care of their kids, they were trying to work from home and so forth, and they didn't have the time or the opportunity to get screening. 45% were more nervous and concerned about visiting a doctor, and this is not in a hospital setting where there are COVID patients, but just afraid maybe there'd be COVID patients in the waiting room or whatever. 1 in 3 women say the pandemic negatively affected their breast care, and 98% women who had mammograms since the start of the pandemic will say they experienced moderate to severe levels of anxiety or fear during the virus, getting the virus during their visit. And it didn't really separate out where the visit was, but I'm sure a lot of those were outpatient centers. Okay, all right, so that concludes my portion. We'll turn it over to questions. I'd asked Dr. Little, he's been looking at the questions while I've been pontificating here, and I asked him to pick out, I'm sure some of the questions are repetitive, but pick out the ones that we thought would be most useful for us to answer. So I'll turn it over to Brent.
And I'd like to encourage you to put any questions you have into the Q&A. And I see one question, which is about how radiography works and perhaps how CT works in patients with COVID-19 because of the isolation status. And I can tell you that we do have some special protocols that we use for patients who are known to be COVID-19 positive. As I was saying, we do have some special protocols that involve masking all patients. If there's an aerosolizing procedure, we have to have the room vacant for a certain period of time after the procedure. But remember that CT and radiography are not aerosolizing procedures. So we mask all the patients, and we have disinfecting protocols. And so we found that we can do CTs, and we do CTs in COVID-19 patients if necessary. For example, for detection of pulmonary emboli, for detection of barotrauma. That's been another big indication because patients with COVID-19, especially in ICU, do have a larger incidence of air leaks and pneumothoraces and other barotrauma. They do have a risk for other infections, complicating infections, and there are many reasons to do either radiography, which can be done very quickly and safely, and machines. Radiography machines are very easy to disinfect and to use at the bedside. So there is, obviously there's always some concern about potential exposures, but institutions have really tried to control that. It looks like there's another question here about, let me read this, the overlap between COVID-19 pneumonia and drug-related pneumonitis, which makes differentiation very difficult. Sometimes the two can even coexist, how to best approach this issue. And I'll let Dr. McLoud, I have my thoughts about that, and I'll let Dr. McLoud talk about that too. But I think that one thing to consider is, of course, whether patients who have these opacities should be tested at all. And I think that my opinion is that if you see something that looks typical for COVID-19, and let's say you have a patient on drug therapy, I think it's reasonable to go ahead and test for COVID-19 because drug reactions can have an identical appearance to COVID-19. And you can try to go by symptoms, but as I've shown, some patients can be asymptomatic in the setting of COVID-19, and some patients can be very symptomatic in the setting of drug pneumonitis. So it can be clinically confusing, but thankfully, COVID-19 testing is becoming quicker and more efficient and more widespread. And so I think that it's reasonable to, if it makes a clinical difference or difference for the patient in terms of isolating herself or himself, I think it makes sense to go ahead and do testing in that case, because there's very little evidence that we can differentiate a drug-related pneumonitis, which often looks like organized pneumonia, from COVID-19 pneumonia. So Dr. McLoud, what are your
Yeah, I would agree completely. I think testing is really the solution when you have this sort of problem. And we're getting faster and faster testing with PCR. So it may take a day or so, but I had to be tested recently because of some symptoms, and I had the result within 24 hours. And I think it can even be quicker. And, obviously in case of cancer patients who may need a decision to be made more rapidly. So I think the key is testing.
Okay, and we have another question here. Are you seeing any mixed infections, which could be a challenge to diagnose? And are there any common typical post-COVID changes? And yes, the answer is yes and yes. We are seeing some mixed infections. There's actually data on this. There's data from California. There was a large ED study in California. I believe it was at UCSF, or sorry, Stanford. And they looked at a viral panel from all patients who came in who had COVID-19, and they found a strikingly high, I believe it was about 20% incidence of other respiratory viral infections. And sometimes what that can do is they can give you, the so-called tree and bud nodules, which are pretty common in a viral infection. Sometimes it can give you some confusing patterns, like sometimes you'll have consolidation if you have superimposed bacterial pneumonia. If you have another viral pneumonia that can cause a bronchiolitis, it can give you tree and bud and other patterns. So it can be confusing. Unfortunately, I think that with the onset of flu season now, it's going to make it very, very challenging. I think that we're going to see a lot of cases that have, two different infections going on, for example, influenza and COVID-19. So it can be very challenging. But oftentimes you can suspect COVID-19 based on the dominant pattern, especially in that intermediate to late phase where you do tend to have peripheral and bilateral opacities. So it is challenging. Dr. McLoud, do you have thoughts?
Yeah, I would agree. I think the important thing is for everyone to have their influenza vaccine. There's a really public health effort to make sure that that happens, but it's going to be very confusing because we're entering that season. And it's fine when the radiographic and the CT findings are very classic for COVID, but that's not always the case. So yeah, it's a dilemma.
And the other question was, are there any post-COVID findings? I just want to bring up one slide here to actually show you. This is what we're seeing more and more of, and there have been a few studies on this, a few small studies, but here's a patient with COVID-19, and you can see the typical bilateral hazy opacities, and in April, and then came back in June, and look, the opacities are actually not gone. In fact, you can see them in the same locations. They're less severe, but they're still there. But look at the CT in September. We still have patchy ground glass opacities, and if you do have a little bit of reticulation, some mild traction bronchiectasis, so a little bit of fibrosis. So we're going to see patients who have ongoing findings, and there are actually patients in our system who have been, I hate to say this, but who have shed virus over the course of months. And, that's increasingly being reported, the so-called long haulers with COVID-19 who either can't clear the virus or have this lasting lung damage. So that's one of the things that we're seeing.
Yeah, if I could just jump in, there certainly are a lot of reports from patients who have symptoms for several months and they just don't really feel back to themselves. And I'm sure that many of them have residual disease. It's interesting about the degree of actual virus shedding. I mean, that's very concerning from a public health issue. So they're testing, I assume, and then are there any recommendations if once that's detected for these patients who maybe have continuing abnormal chest radiographs of CT, should they be tested on a regular basis to see if they're shedding virus?
To my knowledge, there are no guidelines right now since it's going to become more common to see studies of the long-term COVID-19 patients or patients with COVID-19, but we just don't have the data right now to know that. And we don't have the data that correlates with infectivity. That's one thing that we didn't talk about because, just because you are recovering in some, let's say a sputum sample or even a nasopharyngeal swab, if you're recovering virus, it doesn't mean that you're necessarily infectious.
Yeah.
So that's a whole other topic that's going to take, I think, months and months and maybe, more than that to actually be understood. So let's see. And let's see if we have another question. Do you routinely scan oncologic patients with the protocols in our COVID-19 context during their oncologic scans? I'm not quite sure. Let's see, TEP protocol. We may have different names for our protocols, but I can tell you that we are doing, we have universal sort of precautions on all of our patients. Everyone in our hospital has to be masked, and we sort of assume that virus could be transmitted between, anyone in the hospital really and anyone else. So we have universal masking and so forth. And so it has not, prevented us from doing our standard scanning. And you could see that there was a fall off, as Dr. McLoud was talking about, in getting follow-up for cancer screenings and for all imaging for, the peak of the pandemic. But I think that we, in addition to most institutions, have sort of learned to deal with this and with the pandemic. And so medical care must go on. And, I know all of you have seen the studies on how many illnesses and diseases have actually been missed or potentially missed during the pandemic. So, imaging must go on, medical care must go on, and we've really focused on getting things back up to some sort of level of normalcy while maintaining a safe status. So.
And just some statistics from our own institution, to my knowledge, we've only had about 2 or 3 employees in our department, and our department employs, how many? There's about 700 people, if you can believe that. One, unfortunately, was one of our fellows in musculoskeletal imaging, with severe COVID, and he wasn't hospitalized, but he was at home for about 2 or 3 weeks, probably got it from his girlfriend. She had symptoms first. And then one of our technologists who tested positive, but didn't have any symptoms. So the hospital, I think, has done a very good job with very strict precautions, rules and regulations of how people are to interact with themselves and with patients. And fortunately, we haven't had an outbreak of disease, and I don't know, I don't have any statistics on, patients who come in as outpatients and whether any of them are contacted with COVID, but to my knowledge, that has not been the case because of all the precautions. And as I said, a lot of the outpatient visits were halted for a while, although people could have some studies on outpatient imaging centers, but not within the hospital itself during the peak of the epidemic.
And there was another, hospital in Boston where there actually has been a small outbreak. And the thing is, that was actually traced to the lack of a couple of things, the lack of patients wearing masks, and in 1 or 2, it only takes 1 or 2 instances of that to actually develop an outbreak. And that's what happened. There were some, patients who had a mask off and were talking loudly at things like the nursing station. And then the other thing was that people were eating closely together and, without masks on. So those are the things that we've tried to really control and been successful in. So universal masking for us has been really a big success for patients and for providers. Let's see, are there any other questions? I don't see any in the Q&A box here. So, Dr. McLoud, should we
wind it up?
wind it up?
Okay, well, I hope this has been helpful to everyone. It's really been a pleasure for Brent and myself to give this webinar. I want to thank ICIS and all their personnel for helping to organize this. And I know it's going to be the first of several. And actually, we have that last slide. Could you maybe